Good afternoon. This is Dr. Monica Parker coming from the Emory Alzheimer's Disease Research Center Brain Health Center, here to talk to you and start our initial Wellness Wednesdays. So I hope you have a lot of questions for us. To introduce myself, I am Monica Parker. I'm a family physician who's been here at Emory since 1995. In 2008-2009, I became a very active part of the Emory Alzheimer's Disease Research Center, working on their clinical core and their education core. In this capacity, it's been my job to educate people in the Metro Atlanta community about the opportunities to participate in clinical research here with respect to Alzheimer's. Now, why is that important? Because the Emory Alzheimer's Disease Research Center is on the cutting edge and does a lot of research in terms of looking at medications, new diagnostic procedures, and studies to help diagnose people with memory disorders, it's important that you know that we're here so that you can come visit us sometime and participate in some of these studies. Now, what we've been doing for the last 8 years is conducting community brain health forums in local churches, or our biggest ones are at the Carter Center twice a year in April and October. And this year, since the National Institutes of Health has funded us to have a specific core to engage the community, and I serve as the leader of that core, it's called the Minority Engagement Core, we're trying to be a little bit more contemporary in reaching all of you wherever it is you happen to be. So what we're going to do today and in future sessions is talk to you about Alzheimer's disease and related disorders, and give you an opportunity to ask us questions that may not have been asked before. We are not, our funding for this particular enterprise comes from the National Institutes of Health, and we're funded for the next 5 years or so. The Emory Alzheimer's Disease Research Center has been in existence now for about 10 years. We're in our third 5-year cycle. So we are one of the youngest Alzheimer's disease research centers in the country, but we are the only one here in the Southeast. Now, what do we do here at the Brain Health Center of Emory University? Here at the Brain Health Center in Executive Park, we have neurologists, we have psychiatrists, we have sleep medicine specialists, and we have rehabilitation therapies. The Brain Health Center was built and designed about 2 years ago. We've been in here since February 2015 to accommodate all of those different specialties under one roof. The advantage to being here is that we can better consult with across disciplines. You know, if you have a psychiatric problem and you're being evaluated for dementia, you can be seen by a psychiatrist. If you have Parkinson's disease, and Parkinson's disease is a movement disorder, you have a neurologic degenerative condition, but maybe you are having some problems with hallucinations and you need to see a psychiatrist. So you can see one here. Not only can you see a neurologist, a psychiatrist, and you can see a physical medicine specialist who helps with physical conditioning and chronic physical abnormalities. The other things that we have here include the Wounded Warrior Project, or for wounded veterans. They can also come here for physical therapy. We do have radiologic services and MRI, and we do collect blood here, and most recently we've added a cafeteria. So that's the Emory Brain Health Center, and the Emory Alzheimer's Disease Research Center is a part of the Emory Brain Health Center. We do specific studies related to Alzheimer's and related dementias, which gets me to Alzheimer's and dementia. What is that? So we like to call this session Dementia 101. So the bigger thing that I can tell you is Alzheimer's is a type of dementia. There are several different types of dementia. Now, what is dementia? All I'm going to tell you is your brain is not functioning well. There is something wrong, some disease process going on that's not making your brain function the way it should. Alzheimer's disease is a neurodegenerative process, is one of those things that makes your brain not work well. Another thing that makes your brain not work well is Parkinson's disease, stroke-related dementias or stroke-related disease if you have a stroke that damages your brain so your brain doesn't work as well. Alcoholism or substance abuse can affect your brain. Chronic trauma, things like chronic traumatic encephalopathy, the disease that's affecting a lot of football players. And something called Lewy body and or frontotemporal dementia. These are types of dementia that are organic, that start within the person, that cause them to have problems with the way they process information, the way they think, and maybe the way they behave socially. It occurs in people who are much younger. By contrast, Alzheimer's disease, which is the most commonly diagnosed dementia, usually affects people well into after the age of 65. Most people, more than almost a third of the people over the age of 85, are affected with Alzheimer's or a related dementia. Is there any way to cure it? Is there, how many people have this? Well, we estimate that about 5.5 million people in the United States have Alzheimer's type disease. Now that 5.5 million figure doesn't count the types of people who have dementia related to vascular disease or strokes or Parkinson's. Those are different types of dementia, and there's a different number that's attached to those things. But in Alzheimer's, we have about 5 million people. But for people who have other types of dementia, and this is the important part, there are several different types of dementia. Before you call it Alzheimer's, you need to make sure that we've done everything that we possibly can to identify what's causing your brain not to work well. So for the purposes of this discussion, we're going to call brain dysfunction a neurocognitive disorder. And neurocognitive disorders have different sources or different causes. So how do you know that you have Alzheimer's or some kind of neurocognitive deficit? Well, you start looking at what your body does. What does your brain help you do? First thing most people complain about is memory loss. Well, your brain does help you remember things, but your brain helps you do other things. Your brain helps you plan activities. Your brain helps you organize things. Your brain helps you express yourself with language, written language, spoken language. Your brain kind of organizes your body and tells your body to go from point A to point B. That, your brain makes your physical parts of your body move. So if your brain doesn't tell your legs to move, you won't be able to walk and you won't be able to get from point A to point B. So we have what we call domains in terms of the brain functions that we measure when we look for people who have a neurocognitive disorder. One of those things, yes, is memory. Another one of those things is what we call executive function. That's your ability to plan things. Another is language, your use of language, word finding, proper names for proper objects. Visual spatial, i.e., you're looking at something, you're looking at me on this screen, but do you recognize that the me that you're looking at is a person, or is it something else? So your brain helps you interpret what your eyes are seeing. And then finally, one of those things has to do with motor functions. 2 years before most people are diagnosed with a dementia, or Alzheimer's in particular, they have problems with the way they walk. They have problems with their gait and problems with their balance. So what are some of the symptoms of brain dysfunction? Okay, being confused, yes, but also not being able to use your words properly. I'm not saying hesitating about getting them out like when you have a stroke, like loss of speech. That's something different. But, calling your hairbrush your fork, that's not a right, normal process. Or losing the ability to do something you learned to do before, like learning how to drive or learning how to bake a cake, follow a recipe, follow written instructions. Those are signs and symptoms that you may be having some problem. Or if you're observing your parents or an older relative, and one of the things that you look for, we call them soft signs of dementing disorder, are their inattention to their personal hygiene, for example, their inability to recognize that clothes are dirty, or that they put the same dirty clothes on day after day. They're forgetting to take a bath. They're not able to manage their finances. So other than memory loss, there are other things that you should be looking at. And from a clinician standpoint, if I have an older patient who's missing his or her appointments, or when I look at their medications, they're not refilling their medications every 30 days or every 90 days as they're supposed to, that's an indication that this person may be having trouble following instructions and carrying out things. So again, let's recap so we don't go too far ahead, just to make sure that you understand this. There are several types of dementia or neurocognitive disorders. Alzheimer's is one, followed closely by a vascular dementia or something called Lewy body, even Parkinson's dementia. Alcoholism can cause a type of dementia, and in any one individual you can have elements of all of these different types of dementia. Okay, so what are we looking at? What kinds of signs and symptoms are we looking at when we're thinking that somebody has a neurocognitive disorder? We're looking for their abilities to continue to do the things they've always done. Are they following instructions? Are they able to remember things? Are they able to plan their activities, pay their bills, things like that? Are they having trouble walking? Are they having trouble with their physical ability to move from point A to point B? There are several things that we look at. So the domains that we're looking at when we start evaluating somebody for dementia are executive function, that's being able to conduct learned behaviors, memory, language, proper use of language, visual spatial interpretation, i.e. looking at, are my eyes interpreting what I'm seeing correctly, and motor functions. Those are all things that your brain does. Other things, it's sort of like, is there anything we can do to treat this? How do we know? As a clinician and as a primary care clinician, I'm going to tell you, if you observe any of the things we just talked about, you need to get to your primary care doctor and discuss them with him or her. Because a lot of things that can cause your brain to be dysfunctional can be fixed. So what are some of those things that can be fixed? Well, if you're a diabetic and you're not controlling your diabetes well, and your hemoglobin A1C is in double digits, if we fix your diabetes, we may be able to fix something that goes on with your brain. If you have sleep apnea and somebody tells you you snore a lot and you don't sleep well and you feel tired all the time, if you've been diagnosed with sleep apnea, we get you a CPAP, you might be able to think a little better because you're rested. Okay, sleep apnea, and there's some brain fog that comes along with that can be improved with CPAP. Let's say you're depressed. A lot of people with depression aren't able to focus. They're not able to function. Sometimes they get confused. Sometimes they sit in one place, talk, and repeat themselves, and you think it's dementia, and it's really depression. So during the course of your physical exam, your annual wellness visit, if you're over 65, you go in for a checkoff to see if you've done everything you can to protect your brain, to protect your health. One of those things is we do a screen for cognitive impairment, or we do a screen for how your brain is functioning in terms of memory. We also do a screen for depression. Why do we do a screen for depression? Because depression is fixable. So if we diagnose you with depression and we know that's something we can fix, as a clinician, I can write a prescription for that, have you come back a couple of weeks later, and see whether your scores have improved. There's more that goes into the evaluation of somebody with dementia than just doing a 5 or 10 minute screen in the doctor's office. With that, you have to have a comprehensive medical exam. Again, this is to look for the things that are fixable. Aside from depression, which can be fixed, and diabetes, which can be fixed, there's hypertension, which needs to be better controlled. It needs to be under good control. If you have high blood pressure and you're not on any medications, we need to put you on some medications and start you on an aspirin every day to prevent strokes. Why? Because strokes is a leading cause of disability and dementia in the United States, particularly among persons of color, African Americans and Latin Americans. In addition to getting a comprehensive physical exam to look for things that are physical, including vitamin deficiencies. There's a question somebody says, what about vitamin B and vitamin D? Well, part of the medical workup is to check your vitamin B level, your vitamin D level, and yes, you will get a syphilis test, but checking your vitamin D level, your vitamin B level, and your thyroid hormone levels are very important. That's all part of the medical workup that has to be done before we refer you to a neurologist. Now, if all of those things are done, what's the next thing? Well, here, part of that evaluation requires that you have a brain image. We need to take a specialized x-ray of your brain. In most cases, that's going to be something called an MRI, or a magnetic resonance imaging study. It's a pretty fancy study. There are others, something called PET scans, which we're not generally doing on a regular basis in clinical medicine, but we are doing MRIs. CT scans are like what plain x-rays are. They're not as sensitive and they're not as specific as an MRI, but for some people they can't get an MRI, and a CT scan, a plain CT scan, is all we're going to be able to get. So in addition to your comprehensive physical exam to rule out treatable things that may be causing brain dysfunction, we need a brain image, preferably a brain MRI. The other thing that we like to get here is what we call a neuropsychologic test. It's a pen and paper test that measures that demonstrates how you process information and helps us to understand where you may have some deficits. Now, all neurologists don't like neuropsychologic tests, but here at the Emory Brain Health Center, if we think somebody has a dementing disorder, we are going to make sure that they have a definitive neuropsychology test. I like to say this is the IQ test for people who don't go to school anymore. And that's done by a different kind of doctor, a PhD doctor, a clinical psychologist. And we have several of them here. And there are several clinical psychologists in the metropolitan Atlanta area who can also do this. Okay, well, some questions that I have are, if a family member has Alzheimer's or some type of dementia, will you get it too? Not necessarily. If you have a genetic neurocognitive disorder such as Alzheimer's, your risk for developing it is increased, yes. If it is a dementia or neurocognitive disorder related to something like a stroke, that's not necessarily inherited. The risk factors for that stroke, poorly controlled hypertension, high amounts of poorly controlled diabetes, high cholesterol, that's not inherited. Those are learned behaviors, and those things are fixable. So those are things that we need to look at. There are genetics that indicate whether somebody has genes that predispose them to Alzheimer's type dementia. That's not a routine test, and most people's insurance does not cover it. However, through research participation, we do cover that particular test, and a lot of times you will get an MRI, but I'm not telling you to use research just as a substitute for good primary care. I'm just saying that this is part of the evaluation. If you become forgetful as you get older, does that mean you get Alzheimer's? No, it's just like an old car. Some things don't work as well as they did once before, but you'll eventually get to where you're going. So sometimes people do forget things. I'm not 65, but I forget where my keys are a lot of times. That doesn't mean I have dementia. It just means I don't know where my keys are. Okay, so why is early diagnosis of Alzheimer's important? Why do you want to know about this? Why do we want you to get screened for your memory every year if you're over the age of 65? Because the earlier you figure out what's going on, the earlier you can fix it. Patients with chronic atrial fibrillation are chronically throwing little microemboli and blocking blood vessels that supply blood to their brain. Those are what we call those cause what we call microinfarcts, or little areas of your brain tissue that don't get enough blood. It's kind of like a mini stroke, if you will, but it's not obvious. But there are lots of little mini strokes that are going on. But somebody with undiagnosed atrial fibrillation will be throwing a lot of those things, and over time they're going to start to have problems with the way their brain works. Now, once there's a damage done and we discover somebody has atrial fibrillation, does the brain get better? Whatever's been damaged is damaged. It's not necessarily going to get better. But if you control the atrial fibrillation, you minimize the risk of developing a worsening problem, a severe or significant stroke that results in hemiparesis, or like the inability of the body to function on one side, and maybe even to understand what's being said and understand how you can take care of yourself, that allows you to do the things you need to do. How long do people live after getting diagnosed with Alzheimer's? Well, literature says anywhere from 9 to 10 years. But I have a patient who was 105 who died in January, and she'd been diagnosed with Alzheimer's for about 20 years. But she was 105 when she died. So my point to this is, people with Alzheimer's, depending upon what their physical health is, and she was in great physical health, may live a lot longer than 8 to 10 years. Your overall physical health determines how your brain is going to function in the long run. So what can you do to prevent Alzheimer's? What can I do to prevent that? Well, the first thing you do is take care of your body. You don't develop hypertension, you don't develop diabetes, and you don't develop hypercholesterolemia. You participate in active exercise on a consistent basis, 30 minutes, 20 to 30 minutes a day. You keep your blood pressure under control, you keep your blood sugar under control, you keep your cholesterol under control. You have to be physically active, and you have to keep your body healthy with physical exercise and a good diet. We live in the South. Fried chicken is delicious. Fried fish is too, but that can't be something we eat every single day. So it's like, what kind of diet should I follow if I'm older and I don't want to get Alzheimer's? Well, we have something called MyPlate. You go www.myplate.gov. It's a colorful plate that's split into little quadrants. Half of that plate is fresh fruits and vegetables. 1/4 of that plate is a protein, and another quarter of that protein is a little bit of dairy. There's no longer a food pyramid. We have MyPlate. So what kind of diet do you follow? A little bit of protein and a whole lot of green vegetables and fruits. You need to eat at least 5 servings of fruits and vegetables a day. And if you're not doing that, you're not protecting your brain. And you can take supplements, but supplements are only valuable to you if you have a deficiency. So remember I said you go to your doctor for an examination to make sure that we look for things that are fixable. If you have a vitamin B deficiency, a B supplement is going to be helpful to you and necessary because you have a vitamin B deficiency. If you have a vitamin D deficiency, we have high-dose vitamin D such that you take it once every week or once every other week. But you can also take it over the counter. But again, you have to check with your doctor to see if you have a deficiency. Supplements are best for those people who have deficiencies in that particular vitamin or nutrient. Let's see. Okay, we talked about exercise. We talked about food. Oh, one thing that's very, very important. It's not necessarily on the list, but I talked about sleep apnea. Sleep apnea is one physical problem that needs to be fixed, but more people need to take more time to sleep because that's when your body heals itself. That's when your brain winds down and keys up a little bit better. Sleep deprivation is associated with cognitive deficits. So we recommend that people get a good night's sleep. 8, 10 hours, whatever works for you, but you need at least 8 hours of uninterrupted sleep a night. And if you have sleep apnea that's preventing that, you need to get to the pulmonary doctor to get that evaluated. If you're not sleeping because you leave the television on, or you sleep with your dogs, or you sleep with your grandchildren or your children, you need to fix that. You must get regular sleep. A generation or two ago, people who lived in rural areas got up in the dark and went to bed in the dark. You kind of have a cyclical, a natural rhythm, a natural diurnal rhythm. So when the sun comes up, you get up, and when the sun goes down, you go to bed. That's my recommendation for sleep. Important for you to understand, you have to eat well, you have to exercise every day, and you have to get enough rest every day. And if there's something in your existence that's preventing you from getting enough rest every day, you need to eliminate it. Figure out what it is and eliminate it. Now, why am I talking about research? Why is research important? Well, most of the medications that any of us take have been tested on people that don't look like us. If you're female and you're taking antihypertensive medicines, the medicines you're taking were designed for men and not for women. If you are a person of color, it's important to note that these antihypertensive medications were designed and tested on European Americans, European American males, and not females. So in 1993, the U.S. government passed something called the Revitalization Act. And that required that anybody doing research and getting government funds for it must include women, must include children, must include people of all demographic or ethnic persuasions. And if they did not include these underrepresented people or minority people, whatever word you choose to use, and women are regarded as a minority, they had to give a reason for why. For example, if you're doing prostate cancer research, it doesn't make sense to enroll women because women don't have prostates. it doesn't make sense to enroll children because most children don't have a problem with their prostates. It's unique to only older men, so that would be an exclusion. So Alzheimer's and most neurocognitive diseases are not inevitable things, and what we like to do is study normal aging. We need to study how different diseases or different neurocognitive disorders manifest themselves in people who may not have had a history. How are these diseases presenting in men versus the way they're presenting in women? How are these diseases presenting for persons of color versus non-people of color? So we have a number of studies here for memory dysfunction that you can participate in, and some of them are really very painless. One of them involves looking at your eyes and tracing the deposition of something called turmeric. Another one, there's a special exercise study at the VA. And we also have studies on caregivers, or looking at stress risk factors in caregivers. And we look at medications that have been prescribed for other things, like high blood pressure. There's something called an angiotensin receptor blocker, telmisartan or losartan. Those are medications that are used to treat blood pressure that work on something called the renin-angiotensin system. In lower doses, they may protect the brain from developing what vascular dementia, or those factors that figure into the development of Alzheimer's disease. So we have a number of studies. Some you may be appropriate for, some you may not be appropriate for. But we are studying here persons with a neurocognitive disorder, but we're also studying healthy people, people who have no evidence of disease at all. And disease, let's say you had a mother who had Alzheimer's and you don't have any symptoms of it yet. We have studies called prevention studies, the A4 study and the early study, for people who have family histories of Alzheimer's. And in that particular study, we're testing a drug that may prevent the onset of Alzheimer's later. So in any event, we're going to tell you more. I want you to consult our website to look at some of those studies, but I also want you to look at the different opportunities we have for you to get some better knowledge about what neurocognitive disorders are and what they are not. And keep in mind that all primary care doctors and all neurologic doctors may not be aware of all of these things. So I'm going to answer a couple of questions. We've got 3. What are the benefits of B12? As I explained earlier, B12 is an advantage to you. B12 supplements are an advantage to you if you have a deficiency. So part of your medical examination is to test for your B12 levels. And a lot of older people have deficiencies of B12. If you are a person who doesn't eat meat, you're a vegan, you probably have a deficiency of B12 and you need to have it supplemented. B12 is something that you get from eating proteinaceous things like eggs and meat. And for those people who don't eat very many eggs and meat, you're missing a lot of B12. Now I have a question about Lewy body dementia. Are they more combative in long-term care facilities? Well, my comment about that is when you have children in school who are disruptive, they make things a little difficult for other people. If you have somebody who has Lewy body dementia or dementia of any kind in a long-term care facility or a nursing home, they may be combative because, number one, it's not a familiar place to them. The place is foreign, the people around them are foreign, so they're probably not going to behave well. But one of the characteristics of Lewy body dementia is disruptive behavior and participating or doing socially inappropriate things before you have a diagnosis. But any person with dementia may be combative, whether they're in a long-term care facility or not. Lewy body dementia affects people at a younger age than most Alzheimer's type dementia, but anybody with dementia will likely have some behavioral problems at some point in time. And that's because a lot of times they can't process everything that's going on around them. So being in unfamiliar environments, having unfamiliar people touch your person may be frightening to somebody with dementia. So to protect themselves, they may do things. They may kick out They may hit you. They may bite you because they're trying to protect themselves, because you are somebody who's unfamiliar and somebody they may be afraid of. So, they're trying to preserve themselves. It's a response. Alzheimer's gene, what is it? Well, there are several genes that are implicated in the development of Alzheimer's. Most commonly cited is something called the ApoE4 gene. In African Americans, there's something called the ABCA7 gene that turns on the Alzheimer's cascade in the face of poorly controlled high blood pressure and diabetes. But there are almost 22 or 30 other genes that haven't been widely studied that are associated with Alzheimer's. I've just mentioned the ones that are most commonly mentioned and probably best studied. But there are more genes other than these. And as research progresses, we're going to find more genes. So, do I go to a doctor? Do I get a test for these different genes? No. We can do genetic studies for some types of genes. These are not studies that are covered by your insurance. They're usually almost always free to people who participate in clinical research studies. Does that mean you're going to get those results? No. So, in answer to the question, what about genes in Alzheimer's? What about genes in any disease? There are some diseases that have a genetic predisposition, like breast cancer, for example. Breast cancer and ovarian cancer are associated with something called the BRCA gene, BRCA gene. And if you have a family history of breast cancer, you would want to know whether you carry that gene or not. And we've done a lot more studies on that particular gene than we have with a lot of the ApoE4, not just ApoE4, but a lot of the genes that are associated with Alzheimer's. Okay, now what's the question? Okay, is it normal to see behavioral issues with someone at the very beginning stages of dementia? The answer to that question is yes. One of the early signs of an impending disorder is a behavioral or personality change. People who are suddenly mean or maybe paranoid, and they have previously been very cooperative and pleasant, that is an early sign of some type of process. Now, is it just Alzheimer's? I don't know. But personality changes and behavioral changes are indications that somebody needs to get to a doctor for an evaluation. And just because patients do this a lot, I'm saying that if you are observing these kinds of changes in your relative, make sure that you write down what it is you're seeing and see what precipitates that behavior, what comes before that behavior, and how long does that behavior last. Because when you go to your doctor, they're going to want to know, well, what happened when this person acted out? What happened when this person behaved badly? So that's something that's important. Okay, now, what about alcohol? The question is, what about alcohol use? Alcohol is a hard question for me because a lot of people who have neurocognitive dysfunction drink heavily. And there is something called alcoholic encephalopathy, and prolonged alcohol intoxication or chronic alcohol use or alcoholism does result in a type of dementia. And it's always been there. Some people are just becoming aware of it, but alcoholism is a risk factor for dementia as also. My comment with respect to dementia is people who've been nice who suddenly become mean and vice versa. Those are people that you might probably want to look at a little bit more closely. But social habits, people who have ingrained social habits, those are generally not new. Those are generally old. And they're just not hiding it as well because they don't have the ability to do it as well. But that's something that's important to note. One question somebody asked is there any treatment for Alzheimer's? Well, if you have a neurocognitive disorder and the brain has been damaged, there's no medication that we can give you that's going to make that damaged brain work better. If anything, we can look at things to try to keep it from getting worse. That being said, there are several medications on the market for treating Alzheimer's disease. Donepezil or Aricept, Exelon, the Exelon patch, or galantamine or Razidine. a fourth one, memantine or Namenda. These are 4 drugs that are generally used for people with some kind of memory dysfunction or brain dysfunction, but none of these things, none of these things helps improve brain function. They just kind of help with the symptoms. They don't treat the disease as such. Research is ongoing now such that we develop a chemotherapeutic drug or an interventional drug that actually stops the progress of the disease. Like we have certain cancer drugs that actually stop the progression of cancer, and then we have we don't have similar drugs for Alzheimer's. Other questions? I think I've gotten to most of the questions that people have, but one of the things, and I want to thank Mrs. Lopez or Lopes, Karen Fennell Lopes, about her question with respect to the early stages of dementia. I think that when we start looking at dementing disorders, anything that is a change from normal is something we need to pay attention to. So it's important to address things that you see that are different with respect to your relative with that person's primary care doctor. Again, if you have specific concerns that you need to have addressed by your doctor, you need to write them down and be very specific about what you're seeing and what has happened or what changes you're making as a result of looking at those behaviors. But those kinds of behaviors, bad behaviors or tendencies, need to be discussed with your doctor so your doctor can order the appropriate tests. I will say too that some people who have chronic delirium because they're chronically infected with a urinary tract infection or they have dehydration or some other metabolic abnormality, chronic delirium masquerades as a type of dementia. That underscores the need for you to get to your primary care doctor to have a comprehensive physical exam to make sure that everything that can be fixed is fixed and addressed in the appropriate way. And I will tell you that before you get to see a neurologist here, they will want you to have completed a comprehensive medical exam simply because, as I just said, anything that needs to be fixed is fixed and addressed by that primary care doctor. You can't come to a neurology doctor and expect the neurology doctor to take care of your high blood pressure and your diabetes or your sleep apnea. And if you know somebody's drinking alcohol, and I know alcohol is a socially acceptable drug, most people who drink a little bit are actually drinking a lot. At this time, I'm about to bring our little session to a close. I want to alert you that we are having our 13th biannual Brain Health Forum at the Carter Center. The topic this year is Brain Health for Men, What You Need to Know. Women are allowed to come, but we are really interested in having your men come to this particular session. Why? Because we're going to have the psychiatrist there to talk about things like post-traumatic stress disorder and stress in men. We're going to have a urologist there to talk about problems with the urinary tract and the sexual dysfunction, or prostate cancer if you will, and how that affects your ability to be intimate. We're going to have a cardiologist. Each of these persons, the cardiologist and the urologist, are internationally known experts in urologic and cardiovascular disease, so we really do want you to come. We also have an expert from the CDC, Dr. McGuire, who's going to come talk to us about healthy aging. So our lineup with the bigger names are Dr. McGuire from the CDC to talk to us about healthy aging, Dr. James Bennett from Midtown Urology, who will be talking to us about urologic issues for older men, and Dr. Herman Taylor from Morehouse School of Medicine, who will be talking to us about cardiovascular disease and cardiovascular wellness. In the next couple of weeks, we're going to be having more broadcasts on what we call Facebook Live discussions, where you get to talk to doctors and ask your questions. So for our initial visit and our initial foray, thank you so much for tuning in and for being available. We look forward to seeing you at the Brain Health Center on April 25th at the Carter Center. You can call 404-712-1416 for information and registration. Again, that's 404-712-1416 for registration. Thank you.